I'm going to hand over the chairing to Jose Luis Fernandez, who is going to take over my role for a bit, so I can take a little rest. Now I'll be listening as well. Jose Luis, all yours.
Thank you very much, Adelina, and thank you very much to you and all colleagues for putting up such a wonderful set of presentations. So yes, my role today is just to chair, so a very easy role to chair this session on unpaid care, on informal care. The title is a really exciting title and provocative. Informal care is not free and not even cheap. And we've got four presentations with five. I believe at least one of the presentations is a double act. We've got we're going to change slightly the order of the presentations because one of the presenters hasn't been able to log in yet. We're still hoping that she will arrive in time for the session. But therefore, instead of starting with Elena Moore, we're going to start with Jayeeta Rajagopalan, who's actually my colleague at the LSE. So I'm delighted to introduce Jayeeta and to I think we're going to have about 10 minutes presentations to ensure that there's loads of time for discussion. So without further ado, Jayeeta, please go ahead. And if you want to start putting some comments, some questions on the chat, that'd be fantastic.
Thanks very much, Jose Luis. Is it okay if I just share my screen one sec? Perfect, great. First, thank you very much for the opportunity to be here and to share some of our work. So my name is Jayeeta. I'm a researcher based at the London School of Economics. And today I'll be sharing some findings from a qualitative study as part of the Strengthening Responses to Dementia in Developing Countries project. There's a large team involved in this, so I'm just kind of representing them today. So we looked at the economic costs of dementia care in India. So before I get into that, I wanted to provide a bit of background on dementia in India. So the estimated prevalence for dementia in India on adults over the age of 60 is about 7.4%, which is around 8.8 million people over the age of 60. There is considerable variation in prevalence based on various factors, and it varies a lot by states. But despite us having a sizable proportion of people living with dementia, there's only a very small proportion that receive any diagnosis, treatment, or formal care. Dementia diagnosis is often delayed due to low awareness and stigma associated with the condition. We have a significant shortage of dementia specialized professionals, and there's large urban and rural disparities. We do have long-term care services such as residential care services and day centers, but they're in large metropolitan cities and they're associated with significant out-of-pocket costs. So families continue to remain the primary provider of long-term care for people with dementia in India, and there's very limited support for them, both psychosocial as well as financial. Don't know. There we go. So we wanted to understand what are the costs of providing care for persons with dementia in India. We looked at both the range and the nature of direct and indirect costs, but also what are the impacts of meeting these costs for families. And this is part of a much wider study, but we conducted a total of 56 in-depth, semi-structured and repeat interviews with about 24 carers of people with dementia. In 2021, this was at the height of the pandemic, so this was all done via phone. This was done in 2 states in India, one both in the south. One was in Karnataka and the other was in Telangana. And we basically identified carers of people with moderate to severe dementia who are accessing services from a public tertiary referral hospital in Bangalore, and those who are accessing support services, so care support services from a non-profit organization in Hyderabad. And after the interviews, we analyzed the data using thematic analysis using in vivo. So we identified several direct costs which were associated with caring for people with dementia, which are quite well established in literature in low middle income countries. So healthcare costs that include costs associated with consultations, tests, assessments were incurred by all families. Many had visited multiple hospitals and had multiple consultations before they even reached a diagnosis, so that accumulated costs. public hospitals do provide subsidizations through something known as a below poverty line card for some people. But even for some of our participants, even with the BPL card, the costs of like certain MRI scans and all was still a significant proportion of their income. Health insurance is really uncommon. We had two ex-government employees who spoke a bit about it and said that even though that they were eligible, they didn't want to claim reimbursement because the process of applying and claiming for it was very stressful in general. Outside of healthcare related costs, I think medications was a very, very significant cost for low income groups. One of our participants was an older carer for her husband with dementia, received a really small pension monthly, which was her main source of income. And at the time of the interview, the medication cost for herself as well as her husband who had dementia was almost 1.75 times higher than her reported income per month. And we also had a few other cases of low-income participants from low-income groups who had discontinued medications just because they couldn't afford the cost. Then the other significant cost was travel, especially for those residing in rural, semi-urban, or those coming from other states all the way to public hospitals to get a diagnosis. And oftentimes this also led to discontinuation in any follow-up care. So after they had received a diagnosis, like with P16, they were at P18, they had been advised to come back for speech therapy, things like that, but they couldn't afford the travel cost to come back. So that led to, again, discontinuation of care and support. And then we had care support services, and we had very few participants, I guess, who were using these sort of services. And this is what we would call long-term care or social care. And this was mainly paid carers, attenders, domestic help, daycare services. This was mainly in the urban areas utilized by people living there, as well as those who were from middle income or high income families. Services are really costly. And often the paid carers, or as we call them, attenders in India, they are not trained. So there's a significant time investment for families to also train them. And the participants that we did spoke to who used them, they didn't use like services like daycare services very frequently because it was very expensive. And there was also those who had to sell off other assets like land in order to continue to be able to afford to have paid carers come in. And then we identified a range of indirect costs as well. So in some families, the person with dementia was, of course, the main income earner. So losing that income had a very significant impact on the household. There were also carers who had lost wages due to taking time off work, and this was mainly daily wage earners, such as with P6, who had lost almost 17 days of daily wage due to the whole getting a consultation, diagnosis, and follow-up treatment. And there was also, on the higher income groups, there were some that mentioned impact on their education and career opportunities. So with this participant, they had to leave their education in the US behind and come back to India and restart again. And while they were quite content with it, but we know from the wider data set about dementia caregiving that this has quite a significant impact on some lives. We also identified indirect costs that are not routinely noted in costing studies. So one was the impact on financial security, which was mentioned by participants who were much younger, in their 20s to 30s, who were caring for a parent with dementia. And they, for example, with P22, who had mentioned that she had saved a lot of her savings for her marriage, but now that was being redirected to care for her parent. And a few other participants also mentioned this about how a large proportion of their savings is going towards care and support, leaving them with poorer financial security and limited options with how to increase their earnings. Similarly, we also had indirect impacts on participants' health, such as having to postpone or delay any health procedures or reallocate resources, such as in this case. And these two costs that we're seeing emerge in our data largely due to the use of an exploratory approach that went beyond just asking about specific cost components. And this is important because some of the indirect costs were not very obvious to participants when we spoke to them or we discussed this with them. And these insights may have been absent from single qualitative interviews or quantitative data generation. So kind of just to conclude, our findings have highlighted, similar to previous evidence in low middle income countries, that families experience several costs, both direct and indirect, associated with care provision for dementia. And the costs are shaped by the types of support and care provided or obtained and motivations to seek further support. And that's linked to where they live. The South Indian, there's a huge North and South divide, and South India's health systems are a lot more developed. So I do think that there is a slight limitation in our research that way, because we focused on a much more developed area of the country. And the costs are not proportionate to income, in the sense that the lowest income groups are impacted considerably, countering the assumption that just because they don't spend much on care, that doesn't mean that they're not affected. So through our study, we hope that we're able to highlight the nature and impact of these costs, as well as previously unconsidered costs, which can aid in understanding how we can possibly design larger studies to collect more appropriate data in the Indian context for measuring costs of dementia, but also for other long-term conditions. Yeah, and that's all from me. If you want to know more about the STRIDE project, please do visit our website. Thank you very much.
Thank you very much, Jayeeta. We've got a couple of minutes for questions. If somebody, I see lots of digital claps, so many congratulations and a really interesting presentation. Would anyone want to ask a question? Let me have a look. Just please raise your digital hand. In the meantime, I'm going to, ask you one myself. Jayeeta, you obviously are doing research in low and middle income countries, but as well as in, let's say, European context. What would you highlight as the most interesting differences in carrying out research about unpaid carers in the two contexts?
I think that's a tough one. I think there's a lot of cultural differences. I think from working here, I do think that people are more open to things about like residential care and institutional care. And whereas in the Indian context, it's very community care focused. And we did have some conversations with people we spoke to about residential care, and it was like almost like a taboo word. You can't really talk about it. People were not really even interested in it, even if they could afford it. So I think that would be quite a significant difference, because I think people are very much focused on getting support at home. Yeah.
Wonderful. Thank you very much, Jayeeta. Look, I don't see a hand at the moment. Christian Jaramillo, would you like to ask a question?
Yes. Thank you, Jayeeta, for the presentation. Very interesting. My question goes to the context of India policies in general. What do you think is the main obstacles to overcome to improve the current situation in India in terms of social care? And if the government is doing those changes, or if there's a policy around it, if there's already a plan? What you would like to expand on that? Thank you.
Yes, there have been, I think there have been some state level policies. Certain states have made a lot of progress. So one of the states in which we did our study in has recently developed a program that focuses on improving diagnosis and treatment for dementia at a primary care level. So that's one thing. But with the relation to long-term care, they've also established a carer's allowance, which is a very nominal amount of money, but it is something which has started. And there have been national level programs that have looked at, I guess, support for elderly, mainly in terms of social assistance, less long-term care, I would say. I think the long-term care related programs, it's very much focused on providing support at home. So there have been a few trials that have looked at, especially for mental health conditions, which have looked at volunteers from local villages who are trained up to provide support at home. So I think that's something they probably look at exploring and expanding further. Yeah.
Thank you very much. We're going to have to move to the next presentation, but thank you very much again, Jayeeta, for an excellent contribution. So we now have got Elena Moore, who's been able to join us. Elena is Professor of Sociology in the Department of Sociology at the University of Cape Town, and is halfway through, amongst many other things, developing a Welcome Career Award in order to grow a research program in family caregiving of older people in Southern Africa. So I understand you should have been made co-host, Elena.
Thanks everybody, and apologies for this delayed interruption or start. It is Friday, 5:30 here, and I have bizarre commitments at provincial tennis tournaments, but don't even ask me why or where. But either way, I'm here now, and I want to share a little bit about this idea that informal care, or family caregiving as we call it, is not free and definitely not cheap, and the reasons why that might be the case in Southern Africa, and I'll focus in a little bit more on South Africa. Next slide, please, Naz. So just to say a little bit about who we are. So as I was introduced, we run the Family Caregiving of Older Persons in Southern African program, runs across 4 countries. We basically provide evidence and generate evidence on, I suppose, policy priorities, our own ideas around what is family care and how do we make sense of it, what are the challenges, but also in terms of what we find as we go through the program, what are kind of some of the big questions being asked about it, and we explore them further here. So for example, we run a longitudinal qualitative study across the 4 countries, but we also review state spending on older persons. We do some ethnographic work on access to state grants, and we're working across the care economy, aging, social protection, for example, to really get a better understanding of how could we obtain dignified and decent care for older persons in South Africa? Next slide, please, Naz. So as I said, we work across 4 countries, Malawi, Botswana, South Africa, Namibia, and we work with 100 families in each country over time in thinking and listening, really, to both caregivers and older persons about how they're managing care. So we're a team of about 40 researchers. We work with over 60 or plus NPOs, and we've been doing this for some time now. Next slide, please, Naz. And so what we have kind of begun to see is that, well, we know in both policy, or at least in policy priorities, age in place, the idea, the concept is what's prioritized. But a big question we're asking, and where we have not a lot of evidence, but where our job is to obtain the evidence, is what does this place look like? Is it the same types of place that we might see in the global north or across in our counterparts in Brazil or in India, for example? What are the kinds of features of the community-based support that are there or that are not there? And what are family homes? What's the built environment look like? Who's in the home? What are they doing? And what we can see in some of the work we're doing so far is that, at least in policy, there's a lot of assumptions being made about what families can do, and we call this, there's an inherent familialism in expecting families as the primary formation and the primary source of long-term care, and actually fundamentally the main source of long-term care in the region, not only in South Africa. And we show the problems with that. This happens at the same time as there's been a 13% decrease in funding at a community-based level in South Africa, our findings have shown us. And at a time where there's over 4 million older persons in South Africa, for example, who are obtaining state support, like a state pension. And so we ask the simple questions of, well, what are the costs? And is it free? Is it cheap? And is this acceptable? So even if we know the consequences, is it acceptable that we let it be? Next slide, please. So they're the kinds of questions we're asking. Now, in our sample of, and I'll focus in on South Africa here, in our sample of 100 caregivers, 80% of the caregivers in the sample were women. Now, that's not surprising. There's a whole range of reasons for that, which I'm sure is somewhat similar across the world. But what's interesting in South Africa and Southern Africa is at least 20% of caregivers in the sample stopped work or job seeking. Now, this is a time where levels of unemployment are exceptionally high in South Africa. You have up to 50% of youth unemployment. You have about 40% of real unemployment in the country. But you also have a situation where caregiving for older persons is happening at the same time as caregiving for young kids, not just for your own kids, but also other people's kids. So over 1 in 3 of our caregivers were looking after young children. 1 in 3 caregivers were also living with their own disability. So here you see that there's multiple care needs in the household happening at the same time. The vast majority, and I say 90% of our caregivers, are co-residing with older persons. So multi-generational family living is the absolute norm. Adult daughters are the primary caregivers, is probably similar somewhat across the world. But what we see that it's co-residential, but it's happening, most importantly, to remember, in very, very complicated, complex kind of care needs in households with people living with disabilities, caregivers living with their own disabilities, and extensive care needs for household sizes of about 5+ on average. Next slide, please, Naz. So what that means, well, caregivers are having to do a number of things. I'm going to go take you through a couple of examples. So whilst basically 1 in 10 of our older persons had to move to receive care in South Africa, but 1 in 5 of the caregivers had to also move to receive care. Now, this is happening across time and space. And what I mean by that is that it's not just around the corner kind of moving, to the next suburb. This is moving across, from rural to urban spaces, a 6-hour journey in a car, for example, 600 kilometers or 700 kilometers. And these are people, and these are situations where the care needs are so extensive that people can't live in rural areas or in other parts of the country. So if we move to the next slide, we see an example. And here we have these pops of
Elena,
empathy and lindiswa. Yeah.
The sound wasn't brilliant for about probably 10, 15 seconds. I don't know if you want to repeat that last sentence.
Okay. So what I was saying is that and it gives me a chance to say it better, in a country with a history of labor migration, where people move and oscillate between rural and urban spaces, we see the same pattern in.
I have just seen Elena disappear from altogether. So we're going to wait perhaps 20 seconds to see whether she can log back in. Otherwise, we'll move to the next presentation. Let's have a look. Might have been that one of those tennis balls hit the connection.
Thanks. Can you hear me now again?
Oh, you're back. You're back in. Wonderful.
I'm back. The tennis ball wasn't here, unfortunately. So what I was trying to say is that in a history of labor migration, care takes place over huge, vast distances. And so caregivers, and this is now multiple generations, both young generation, as in like 20-year-olds, adult grandchildren, and the adult children who may be 40 or 50, are moving, to rural areas temporarily and managing the care needs of older persons who are preferring to live in rural areas. So here's an example where empathy, for example, lives in a rural area, which is about 600 kilometers from Cape Town. Now, as her care needs change and as she requires more and more care, Lindiswa, who has a full-time job in Cape Town, realizes that this is becoming very difficult to manage. So she asks her adult daughter, who's about 20, to move to the rural area to look after the granny. Now, she does this for 3 or 4 months and returns back, but obviously the older person's needs don't really change. They get worse, actually. And so over a 7-year period, we map the movement of both the caregiver, young generation and middle generation, and the older person eventually then having to move to Cape Town. Now, this is happening in a situation where people are having to make life choices. So the 20-year-old who was in training in Cape Town was asked by her mother to move to the rural area to look after her grandmother. And again, that has consequences for both the caregiver and also for the adult child as well, Lindiswa herself. Next slide, please, Naz. So what we're saying is that caregiving isn't straightforward. People are having to make choices, family members and adult daughters in particular. The other choice that I alluded to is that people have to give up work at times of very high unemployment. Here's one example, Zipo. She's a 42-year-old single mother who's living in rural KZN, KwaZulu-Natal, on the Durban side of South Africa. She was working, but her mother had an accident and became quite ill and needed full-time care. Now, temporarily, the grandmother, the mother as such, the older person, could be looked after by an aunt, but that was only temporary. So basically, Zipo had to relocate her entire life to be able to give full-time care to her mother, who lived, again, 6 or 7 hours away from where she had employment and other opportunities. So we're saying that people are having to make life choices, but the balancing of these are incredibly difficult. It's a moral dilemma, it's like an economic dilemma, it's a care dilemma, and it's coinciding at a time, as I said, with high levels of poverty, and these are really not fair choices to put on, particularly adult daughters. Next slide, please. Now, care happens in incredibly disabling environments. So South Africa being probably a little bit better than other parts of Southern Africa, people have very poor access, particularly to sanitation, so indoor toilets, to tapped water in their own house, and to energy sources. So many people have to go and collect water, which obviously takes time away from care and adds to the care like work. They also have to, older persons often have to use bathrooms or toilets that are outside of the house. They have to navigate that both in terms of security, but also in terms of mobility. And needless to say, that often takes up quite a lot of assistance and time. And so caregivers, the level of care work is not only a feature of the different people in the household who require care, but the environment, the physical and the like built environment in terms of particularly access to services in rural areas, but also poorly serviced areas in informal settlements in urban areas. Next slide, please. Now, and I don't want to say what's interesting, but what's peculiar in this context is South Africa will always be heralded as having fantastic laws and policies. And one of those fantastic policies is that there actually is, the state is mandated to supply adult incontinence products, as an example, to older persons who have been diagnosed and are under prescription for having to use adult incontinence products. The problem is there's no stock, there's no adult incontinence products, and there's no, how would I say, transparency or accountability of whether this is actually happening equally and fairly across all sites across the country. So whilst it might happen in one community, an hour across another way, particularly in informal settlements, there's absolutely no supply of adult incontinence products. Now, we're currently working on a small project to try and improve the situation. But as we all know, adult incontinence products are incredibly expensive, but they're not just expensive. In their absence, they create huge amounts of work for caregivers and the older person. So they have to manage care in ways that could be assisted by not only wheelchairs, assisted devices, but actually material items such as adult incontinence products. Next slide, please, Naz. This penultimate, I suppose, or the third last slide I have here is the work that caregivers need to do in managing food and food security. When with high levels of poverty and with inadequate social protection for all members of the family, not just for the older person, older person households are scrambling to be food secure. And so caregivers are kind of creating strategies of how do I manage the food bill and food security. And so here are a few examples of what they do. They access, subsidized food if available in the local school or the religious organization. They borrow from neighbors, they borrow from loan sharks, they obtain credit from local shops, informal shops. Now, some of these strategies are very costly, such as borrowing from a loan shark. And many of our households, about 40% of our households were in debt, heavily indebted to loan sharks, because of food, not because of, other conspicuous consumption, for example. So here we would advocate, again, the government, we need older persons to be incorporated into national feeding schemes in similar ways that children are, and has been very fruitful in South Africa for children. And my second last slide here, sorry, Naz, next slide, please. Is all of this comes together. We talked about mobility, we talked about making life choices, we talked about having to give up work, having to manage other care needs, having to manage food, having to manage disabling environments. All of this comes together in tensions in the household. Caregivers feel stressed that they themselves are not earning. They're managing unemployment and high care needs and poor food intake. And so we see that families are not coping. And so the assumptions that are really being made is that, as I said at the beginning, the family has the capacity to care, that caregivers, are able-bodied and can care, that members are available to care, either being in the same city, the same street, or having no work and are able to manage that work-life balance or that work-care balance, that family members actually will help, because obviously there are family members who don't help, and that helping is evidence of good care. And we are very concerned with, just because of a high levels of co-residence doesn't mean that caregiving is actually happening and good quality caregiving is happening. So we argue that living at home within the community, it doesn't always maintain and promote the well-being of older persons. And we have to be very careful of how we think around the concept of aging in places that are tricky or complicated, both in terms of the built environment, but also in terms of access to services, particularly in terms of mobility. Thanks very much. Thanks, Nas, for your help with that.
Thank you, Elena. A really interesting presentation that shows the challenges involved in providing unpaid care. If somebody wants to ask a question, it would need to be very, very, very quick and with a even quicker answer. So I'm going to give 3 seconds to somebody if they want to raise their hand. 3, 2, 1. So again, Elena, thank you very much for a fantastic and good luck with the tournament if that's what you're doing. Okay, fantastic.
Thanks.
We're going to move to the next presentation, which is a double act between Cristina Vilaplana-Prieto, who's a professor at the University of Murcia in Spain. She's an economist and has one of the things that she highlights in her GOLTC profile is that she herself has got direct experience of being a carer. And also my colleague at the LSE, Joan Costa-Font. I don't know, I'm not too clear as to who's going to do the presentation. Joan, is that you or is it you, Cristina?
Both.
Both? Okay, well, I'll let you organize yourself. Good luck. I'm looking forward to listening to the presentation.
Excellent. Well, thank you so much for the invite. Sounds like really interesting set of events. And I'm already learning a few things I noted down from previous presentations. So this, as you mentioned, it's a double act. This is a joint paper. Basically, we thought it would make sense to go over the key ideas. I'm not going to get into any detail on the paper. That we basically illustrate an answer to the title of this session, estimating actually how valuable informal care is, and we show that as the title suggests, is actually neither negligible nor cheap, right? So it's actually quite significant. So let me just give you a bit of a preview of what this paper was about, and I'm looking forward to an interaction both today or looking forward. So what we are doing here is we are estimating the value in terms of informal care in terms of the compensating surplus. So the amount of, let's say, income that you would have to compensate a caregiver to be equally well as a non-caregiver, right? And the reason why we think that this is the right way to measure the value of informal care is because informal care generally has detrimental effects to the well-being of individuals, but sometimes it can have beneficial effects as well, right? And we'll talk a little more later on. And the only method that integrates both detrimental and beneficial effects would be this method. And now what we do in this paper is econometrically, I'm not going to get into details, but we estimate a causal estimate of the effect of caregiving on well-being using a well-established, let's say, instrument in the literature. So the idea is that we, unlike some previous studies that were very much like country-specific, this paper is actually comparing the value of informal care across a set of European countries. And we rely on an estimate of the effect of caregiving on well-being that is, we believe, very precise. So it's not biased, right? So that's basically the idea. And not only that, I mean, because we have longitudinal data, we can distinguish between income measures that are both permanent and transitory. And this is important because we show that actually when one looks at permanent income, which hasn't been done in the previous literature, actually the effect is a bit lower. So the value of informal care, the value of care is actually a bit lower than when estimating the effect using transitory income. Now, what else do we find? Well, we essentially find that, as expected, care reduces well-being of individuals. So being a caregiver, on average, makes you a little worse off, right? And this effect at the aggregate level is not massive, but if one looks at co-residential caregivers, the effect is, on average, 6%. So there might be large heterogeneity here, but if one, literally boils together all the co-residential caregivers, the effect is significant, and it's 6% less well-being as estimated by life satisfaction. And we estimate values of care that are very large in some countries, like France, for instance. So the value of care in France is about 4% of the GDP of the country, right? So this would be about 1/3 of, let's say, the amount of funds that they invest in healthcare. And in other countries like Germany, we find that much smaller value. And the reason being for that is because they have quite a significant network of formal caregivers. So what we interestingly find is that in countries that they have higher investment in formal care, right? What we see is that the value of the informal care in the country is much smaller because actually they provide less informal care, right? Because most of the care that is provided in, let's say, in Germany, or a significant chunk of the care provided is actually paid for, right? So it's not unpaid. And then we move on to then look at another survey and estimate the value of informal care per hour. And across Europe, we come up with an estimate that is about 9.5 euros per hour across Europe, right? Which would be about the minimum salary in Spain. But actually, this ranges quite significantly between 22 euros in Switzerland, which is literally the minimum salary in Switzerland, to 5 euros in Spain, which is far below the minimum salary in Spain. So this would be basically a preview of what we do. And now I'm going to get into a little bit of detail without actually providing a lot of let's say, context, because we won't have the time. But as I said, I mean, care has both detrimental effects. For instance, lowers the caregiver's wages. On the margin, increases the incentive for retirement. It increases morbidity, mortality, stress, anxiety, depression. So there is a number of studies, and I'm sure that I'm just like quoting like a selection of them. There's probably 10 times more studies than the ones I'm quoting here. And then there are actually beneficial effects, presumably for caregivers, because individuals are fulfilling a social norm. They might actually connect with their family members as a result of providing care, and so forth. So, what we do is we estimate the value of informal care, taking into account both positive and detrimental effects. The alternative to our method, which is the well-being method, would be using contingent valuation, which would be essentially asking individuals for their willingness to pay not to be a caregiver or to accept to be a caregiver. The problem is that these will be hypothetical questions that are affected by protest responses and are widely disregarded in the literature. So now I'll hang on. I'll basically pass on to my co-author, Cristina. So you're welcome to step in, and I'll just let me know when I need to change slide.
Okay. So we use data that come from the 7 usual waves observed that cover the period 2004 and 2020 for 10 countries, and we also include their life. And this is the equation that we estimate, where LS is life satisfaction, measured on a scale from 0 to 10. CI is the current income of the individual in logarithms. LTI is the long-term income of the individual for the period 2004-2020. We have computed the long-term income following the methodology proposed by WAIS 2012. IC denotes being informal caregiver, and alternatively will be replaced by 2 variables: co-resident informal caregiver and non-co-resident informal caregiver. W represents time varying explanatory variables, for example, age, marital status, household size, relationship with economic activity, self-reported health status, and the Charlton Comorbidity Index. Zeta denotes the time invariant explanatory variables. We introduce variables related to respondents' childhood and adolescence, since adverse events experienced during childhood, like family characteristics and education performance, are related to present life satisfaction. We also include individual and year fixed effects. So next slide, please. Given the pooled effects or random effects model are susceptible to omitted variable bias, we draw Pesaran and Su approach, which is now the fixed effects filtering model, which provides a two-stage estimation model retrieving consistent estimates of time invariant variables when individual fixed effects are assumed to be correlated with other regressors in the model. We use instruments for informal caregivers, the traditional instruments, number of daughters, the number of sons, being the eldest son, youngest son, and being single child. Another issue is that we consider the effect of income satisfaction has a serious endogeneity and omitted variable problem. For this reason, we also estimate both variables, current and long-term income, using the income of the partner and the income of the other household members. Finally, we obtain the compensating surplus following the procedure proposed by Lochinger and Rasky in 2009, where CI bar and LTI bar denote the mean of the current income and long-term income respectively. So in this slide, in this table, we appreciate the estimated coefficients. In the red boxes, we observe that being a caregiver has a negative impact on life satisfaction, higher for co-resident caregivers and also higher for women. In the blue boxes in the upper part of the table, we appreciate a higher negative effect for co-resident caregiver for both men and women, and also that current individual income has a significant and positive effect and is higher for men. In the lower part of the table, we observe that the effect of long-term individual income is positive, is also higher than the effect of current income, and also higher for men. Thank you.
Great. So just to conclude, we estimate the effects that I mentioned in the introduction, and what we see clearly in our estimates is that there is a negative correlation between investment in formal care and the value estimated of informal care as expected, and this is true, irrespectively of whether we use, let's say, estimates of local long-term income, or whether we estimate the compensating surplus per hour. As you can see here, perhaps with a compensating surplus, the negative effect is less visual, but clearly you see that there is wide variation across European countries. And just to conclude, these methods used here compare reasonably well to alternative methods of estimating informal care, such as the replacement method or the opportunity cost method, which basically are not based on preferences at all. I mean, those alternative methods assume that the value of caregiving is either the value of a formal carer in the market or the value of the alternative use of time of the informal caregiver had the informal caregiver gotten a job in the market. So when we compare the methods, what we find in the last two columns of this table, if you look at the estimates, you will see that there is a study by Peña Lombardo using, if I remember well, replacement method. And in those methods, because they are not based on preferences, they don't take into account the potential positive effects of informal caregiving, and they tend to overestimate. They provide really large estimates of informal care, whilst using our methodology, we still find estimates that are very consistent, but they have a slightly lower value. So I'll stop here and look forward for questions.
Okay, we will have time for one quick question, very quick question. We are accumulating delay, but thank you very much for a brilliant presentation, which shows the breadth of methods that are being used to look at unpaid care questions. So any burning questions? I think there was a question on in the chat, but it has been answered by Cristina, and also Adelina has posted the link to the paper. So I recommend everyone reads the paper and quotes it, references it very frequently. I'm sure, Joan,
thanks so much.
You're keen on that. Okay, so we better move to the last presentation. Thank you very much again, Joan and Cristina. And the last presentation is by Cassandra Simmons from WHO Europe. And I hope that you're ready to start.
Yes, so let me just try to share my screen here. And so I'm hoping, how are we? Do you see the presenting mode or?
That's now perfect. We see.
Perfect. Excellent. Okay. Thank you very much, Jose Luis, and thank you to Adelina and Naz for the invitation to speak in the session today. And thank you to everyone for sticking around. I understand it's been a very long day. So as the last presentation in this session, then I'm going to talk about some work that I had carried out with colleagues Ricardo Rodriguez, who's at the University of Lisbon, and also Kai Leisenring, who is at the European Center for Social Welfare Policy and Research in Vienna. And in line with this session's topic, this chapter that we had worked on together was actually published in the Care Dividend, which was published earlier this year. And specifically, we were looking at the burden placed on the financial situations of families in Europe. And more specifically, in this chapter, we looked at two aspects. So the first, we wanted to look at out-of-pocket payments for home care services, which is not going to be the focus of this presentation. But the second was also looking at the financial impact of caregiving on informal carers. And so what we already knew from the literature is that a large share of families' contributions to long-term care is actually in the form of time rather than out-of-pocket payments. And as we can see from the last presentation and also from literature in general, the value of informal care is quite high across European countries. And it's been calculated as high as public expenditure on long-term care in quite a lot of countries, even in countries that spend quite a lot on long-term care. So we know caregiving then competes for time, which may then in turn impact labor and earnings of family care members. And we also know from past literature that informal care tends to be concentrated among poor individuals. So this idea that there is going to be some sort of financial implications on families. So just a very quick description of what we had done in this chapter. It was quite simple. We looked at the shared data survey on health, aging, and retirement in Europe. We used waves 4, 5, and 6, which were carried out every 2 years. And we looked at a sample of informal carers aged 50 to 64 across 10 European countries. And we basically just compared their outcomes in the period immediately before taking up care and immediately after starting to provide informal care. And of course, I have to then caveat this with saying, you know, this is not a causal estimate. We cannot account for selection effects, which we do see, we can tell. We don't account also for endogeneity. So, you know, the decision to provide informal care can often be correlated with health as well. So, and with other characteristics that we can't control for. So we really just use a very simple method of looking when an informal carer transitions into providing informal care, how does this affect some of the outcomes we're interested in? And what we looked at was employment. So whether the carer was employed and then consequently the number of hours of work. We looked at income as well. So how equivalized household income changed. And then we also looked at the risk of poverty, and we used two concepts. We looked at the concept of impoverishment, so whether the individual was pushed into poverty as a result or with the transition into informal caregiving, and then the concept of further impoverishment. So was the informal care already below the poverty line prior to starting to care, and were they pushed even further into poverty once they started providing informal care? And we use the threshold of 60% of national median equivalized income as our poverty thresholds. And just to clarify, when we're talking about informal care here, we're talking about providing personal care, both inside and outside of the household, as well as home help provided outside of the household. These are the questions that SHARE uses. So jumping right into the results then of what we saw when we looked at the transition to providing informal care. So in terms of the impact on labor, when informal care is transitioned to providing care, about 10% exited the labor market. We saw a variety across countries. I'll get to that in a second. We saw that around 22% of informal carers reduced their working hours, and this tended to be on an average of 8 hours less of work per week. So automatically, we saw that there was a reduction in labor market participation among informal carers, but this was more so among the lines of reducing hours rather than dropping out of the labor market altogether. In terms of income, what did we see? So we also saw that quite a large share of informal carers experienced a deterioration in their financial situation. So between 39 to 50% of carers across countries reported a reduction in their household income. And this was on average about 35% lower. And now keep in mind, this is at the household level, not just what the informal carer was making. So we could envision why there could be a reduction in income that goes beyond just the employment of the carer themselves. But something interesting to note that shows really the nuances of the situation across European countries is that some households actually experience increases in income. I don't have the exact figure here, but it seems a little bit counterintuitive. But when we broke it down and looked into the possible reasons for this, We saw on the one hand that some households were withdrawing savings, so liquidating assets to be able to smooth their consumption over time. There was also intergenerational transfers, so between the person receiving care, passing on transfers. And then the partner might have also increased their own labor to increase income. And then finally, some transition to taking up old age pension. Now, as mentioned, we did see some differences across countries, which certainly speaks then to the varying extents of social protection and support and availability of services across countries. So in some countries, it seems that there may be better opportunities to combine informal care with work. And I'm referencing Sweden particularly, where only 4.9% of carers stopped working when they transitioned to provide care, as well as Switzerland, where only 6.4% of informal carers stopped working. And we can see that a larger share of carers in these two countries reduced their working hours, suggesting that there are some mechanisms allowing them to reduce hours and perhaps to better reconcile work with caregiving responsibilities. We also saw that there was a low share of carers. Well, we saw in the case of some countries like Spain and Italy, where there were a lower share of carers reducing their hours than what we might have expected. And what we thought the reason behind this might be is that this reflects differences in the type of people that take on caregiving responsibilities. So we know that in these countries, there's a lower labor market participation rate, sometimes among women. So this could be reflected in the lower share of carers that reduce their working hours. It could be that the would-be carers were already not working to begin with. I see I'm slowly running out of time, so we'll try to pick this up a little. We looked at then the effect of caregiving on the risk of poverty. And what we saw is that between 4.3% and 12% of informal carers were impoverished as a result of transitioning into caregiving. On average, about 7.5% of informal carers. And about 4.6% became further impoverished. So they were already below the poverty line to begin with, and they were pushed even further into poverty once they began providing informal care. And what we noticed across the countries is that impoverishment seemed to be highest in the countries that do have cash for care benefits as their main mean of support, that are also linked with having more limited formal home care availability, and generally where we see that informal care tends to be quite intensive. And my last slide of results, we also looked then at the poverty rate before caregiving and then after uptake of caregiving. And we see a bit of a complicated picture, actually. So we see that quite a large share of carers were actually below the poverty line before they started caring, which in part probably also speaks to, again, the type of individuals that do take on informal care. They may be people that are already not working or maybe quite low income and not able to pay for home care services, for example. But what's interesting is that, so we do see in a few countries where the poverty rate was very high prior to taking up care, we actually see the poverty rate reduce in these countries. And I'm speaking specifically about Spain, about Italy, and about the Czech Republic. And we looked at this, and it could be a case of short-term effects of taking up social benefits, for example, cash for care benefits as well. It could be that these carers were previously marginally employed, and it could also be the result of cohabitation. But we also see that in some countries where the poverty rate was not so high prior to uptake of care, we see a slight worsening of the poverty rate afterwards, which speaks then to the inability of systems to properly protect informal carers when they do step into a caregiving role. Okay, last slide, just summarizing very quickly then what we found in this chapter and what the implications are. So we found that carers do find themselves in precarious financial situations across European countries, often even before taking up care, which care then even further exacerbates. So informal care is not cheap, and we see this, that there is an effect of caregiving on employment and income, and these can be quite substantial. And we see that there's an increased risk of poverty amongst carers, and we find that this does seem to be associated with countries and the level, the type of systems and what offers are there, particularly among countries that are considered familias. And if we think that informal care is considered as a sort of in-kind subsidization of long-term care by families, then we see that it's disproportionately paid by lower income families. But I do want to stress that we've just looked at the short-term effects of caregiving, the immediate short-term effects, and it's very likely that these are exacerbated in the longer term, especially if informal carers stay out of the labor market for longer periods of time. So of course, making the case that income maintenance policies are very important, social benefits that financially protect carers, especially in the longer term, and then finally expanding access and eligibility to long-term care services are all crucial so that we can ensure that informal caregiving is a choice and that people are properly protected, not just short-term, but also in the long term. So I stop there. Thank you very much.
Thank you very much, Cassandra. What an interesting presentation, and also the best at keeping to time. So thank you very much from me on that. Well done. Because we started at 3 minutes past, we've got questions of time for 1 or 2 questions. Elena, I don't know whether you're still there and whether you wanted to ask your question.
Sorry, but I'm in Ukraine and no electricity now here, so I'm trying to without video. Yeah, I just looked at the table which you presented, Cassandra, where you said that in Sweden there is a lower share of dropping out of the labor force, but greater share of reducing hours. And then I just couldn't help but notice that it also had the highest percentage reporting drop in income after taking up caregiving responsibilities. And I did some work on motherhood wage penalty in the past, and I wonder if that's a penalty for part-time work, which can be responsible for that. Because it sounded, when you said it, it sounded like positive, but if they are more impoverished, then yeah, thank you.
Yeah, no, thank you very much, Elena, for your comment. Indeed, on the one hand, I mean, if we do look at the employment situation, then Sweden looks like a great example. Less than 5% of informal carers drop out of the labor market. Some reduce their hours, but then we see quite a large reduction in income. But we didn't distinguish between full-time workers and part-time workers. And I think that this would probably help to try to disentangle where exactly these vulnerabilities are coming from. I know that Sweden does tend to be praised as a country that is quite advanced in terms of long-term care and also support for informal carers. But I think this does highlight a very important point that even in a system as advanced and developed as Sweden, we still see quite large financial implications for informal carers. And it's a question of finding out and disentangling further of where these vulnerabilities come from so that we can address them. So thank you for your comment.
Thank you very much, Cassandra, and thank you very much, everyone, for joining this really, really fascinating session on unpaid care, digital club by everyone for everyone. And over to Adelina, perhaps, to introduce the next set of presentations.